so this is low key. Yeah, don't worry about it. Okay, so what I want you to do in here is tell me everything that you're doing.
Okay.
Why don't you come up here, I want to show you how to get these meds when we get to the point that you're administering. When you want to give something, turn the stopcock towards the syringe,
Okay.
put it on here, keep your hand out from in between the reader, administer what you want with it aimed towards the syringe. When you're through giving whatever you're giving, always tell me what you're giving, so if it doesn't read in there, I have it written down.
Okay.
And then turn it off, and then take it off.
Okay.
Okay? So like that until you can put it on.
Yes, sir.
Check. There. And there. And you can kind of set this up as you're talking to me, knowing that you got what you want. But let's just say the first thing of the morning, you came in and you were assigned to room 10, OR.
Okay.
When you come into the OR, you were just out there doing something. What were you doing before you went in the OR?
I scrub my hands, put on my surgical hat, and put on my surgical mask.
Okay. And what else? All your PPEs.
Oh, my PPE, my surgical scrubs, my booties,
Okay.
and yeah, and my surgical scrub, of course.
Okay, when you got all that, you come into the OR and you come into the OR. What are you going to do now? Nobody's in here yet.
First off, we have the GE Datex newer machine, so I'm going to go ahead and turn off my machine and power it back on so it does the system check.
Okay.
And then I'm going to go through my system check, checking, making sure I have the external battery back up, so I'm going to disconnect it from the wall. I'm going to come back here and I'm going to hook up from the oxygen tank from the main supply, flush this, get that to 0, open up my oxygen tank, make sure it's at least 1,000 PSI according to boards, and then make sure that the alarm is alarming me, and open that up, alarm goes off, close it, put this back down to 0, hook back up my main oxygen supply, make sure that the alarm goes off, so I'm good to go there.
Okay.
Come over here. I'm going to turn on my monitor. I like to take the oxygen gas sensor and puff on it a couple times, make sure I get a pleth on my end-tidal CO2. And I'm going to go ahead and do my 21 oxygen percent. I'm going to go ahead and do my 100%. Good there. Calibration.
Okay. So you've done your complete.
Done my complete
Machine check.
Machine check. Then I'm going to just make sure I have my equipment out. Stethoscope. I like a Mac 3, Mac 4, a Miller.
Okay.
ET2.
All right.
7.5. Did my little check. It's all my airway equipment.
Okay.
Come over here. Now that I'm in the room, the patients and all my drugs are out and labeled and drawn up and ready.
And there was one thing you may have said. Anything else in your whole setup? What other thing absolutely have ready before you start a case?
So this is full.
Yeah.
Airway, suction.
Suction.
Suction's hooked up.
Okay.
And
it works.
And it works. I like my salt suction airway. Suction here, coming around. Then my airway, which is my oral airway, and my laryngoscope and my tube. That's how I line it up on my cart.
Good.
Salt.
All right. So you've got your room all ready, and you've even got your drugs drawn up. I saw that you're ready. And what you got, somebody saw him out in the pre-op, and they come back and just very quickly tell you it's a 51-year-old man who's going to have a laparoscopic gallbladder, and he's about a 20-pack year smoker. But he doesn't really have any other history, no cardiac problems, no pulmonary problems, just that he's a smoker. So.
Okay, 20-year-old smoker.
And he weighs about 160 pounds.
160 pounds,
Uh-huh. No allergies.
I'm going to call that 80 kilograms.
Okay.
I may have to do a calculation.
All right. And actually, they're bringing him down the hall.
Okay.
So the first time you're going to meet him, he's coming in the room.
72 kilograms.
Okay? And he's coming in the room. You're just meeting him.
All right. Hello, Mr. Smith. My name's Dallas. I'm a SRNA. Just going to be one of I'm a student registered nurse anesthetist. I'll be doing your anesthesia today. Nice to meet you.
Good to meet you.
All right. Can you tell me your name and date of birth?
My name's John McEnroy.
All right, John. Can you tell me who your surgeon and what you're having done today?
Dr. Nice Guy.
All right, nice. And what's your surgical procedure today?
They're taking out my gallbladder.
All right.
And I am scared.
You're scared? Okay, John. Do you have any questions about your anesthesia today?
No, the doctor in the other room explains you're going to be putting me to sleep and you give me some medicines to make me feel better.
Yeah, John, now that we got you on this OR table, I'm going to just hook you up to my blood pressure cuff on the arm that is not running down IV and the pulse oximetry, so left arm, and those on the right arm. So let's go ahead and start your blood pressure. It's touchscreen.
It'll do it.
Oh.
Like what you're seeing is good.
Oh, there it is. Sorry. Yeah.
And it's-
Okay.
yeah.
All right. It's got your blood pressure. It's going to hook you up to the monitors. Yeah. Got some oxygen for you, Mr. John. You mind if I call you Mr. John? Is that okay?
Sure.
All right. This is oxygen. No gas. Just get your lungs filled up with oxygen. Take some nice big deep breaths for me, okay? So got my blood pressure. It's hooked up on the monitor. Got your pulse oximetry on 98%. Got you on
You know, this one let's use mostly air.
oh, okay.
But tell me that you're...
Okay, I'm pre-oxygenating with 10 plus liters of O2
Okay.
for induction.
And turn on air.
So like 2 and 2?
Just do mostly air.
So,
Just turn on whatever you want, 6 liters of air, whatever, and just turn on a little bit of O2.
oh, I got you.
But in theory, you're telling me you're giving him 100% O2.
Perfect.
Okay.
All right, Mr. John, got you hooked up to the monitor. We want to give you some medication to help you relax, sir. 60-year-old male?
Yes.
60-year-old male, relatively healthy. I'm just going to give you 2 milligrams of IV for Versed, midazolam. It's going to help you relax. Can't really see how
That's
much
okay.
mils is anything. 1 milligram per meal. And infusing, giving 2 mils of
2 milligrams of Versed.
Versed. Okay. How you feeling, Mr. John?
I'm kind of scared.
All right.
It smells funny.
Smells funny?
Yeah.
Huh.
Looks like a balloon.
Yeah, that plastic, this mask kind of smells like a fresh shower curtain, I like to say. Brand new shower curtain. Got some pain medication for you, Mr. John. Go with 100 mics of fentanyl on IV induction.
Okay.
Two mils given.
100 mics of fentanyl.
Nice big breath, John. Doing
Okay.
great. Now this is warming. This is this medication I'm going to give you. It's going to be warm going in your IV. It's numbing medication. Stick with the 1-to-1 ratio on the lidocaine. So 7 mils of lidocaine, 70 milligrams. All right, John, pick out a good dream. I would have had my tape wide
Okay.
here, which I don't have.
You just tell me.
So, and then I also put tape here for the eyes, which I will verbalize.
Okay.
All right, John. Got a good dream picked out, sir?
Yeah, I'm ready to go sleep.
All right. See you in a bit.
How much you give?
150 milligrams of propofol,
Okay.
or just over in two.
150 milligrams of propofol.
Nice big breaths, John. You're doing great, buddy. John? John's still blinking. The blood pressure's a little soft.
So if he was still blinking, what would you?
I'd infuse 50 more.
Okay, go ahead.
If he was an older individual, I'd wait for the circulation time. Oh, okay. Take his eyes. I'm going to give 2 breaths, doing my CE on the mask. I'm going to chest rise. And the end title.
Did he go to sleep?
Yes.
Okay.
All right, so I can mask this patient. So I'm gonna go ahead and go with the roxuronium. So I can.
Okay. How much would you give this guy?
Well, gallbladder is relatively short. This is Dr. Coy. He's very fast.
Okay.
25.
25 milligrams?
Yeah, 25 milligrams.
Yeah, liquid. Okay, and just only get like a half cc of that.
Because
Otherwise he will think you're paralyzed.
Okay.
25 milligrams of rock.
So I like to hit pause on my here, and then that gives me a countdown timer at 3 minutes, so I can know, when onset time of the rock is.
How else are you going to know that it's time to intubate besides time?
Fill in the bag.
Okay. He's quit breathing with propofol, and you might feel the difference. You might get easier, but how else are you going to tell? You got any monitors on that you're going to be using?
My end time?
That works.
Okay.
So you're going to be monitoring his neuromuscular blockade, probably. And you can check it whenever you want to. And it's probably, you're going to see bunches of twitches out there because we didn't give the true amount. Hold it down. That's tetany. Hold down your hold down your twitch. Hold down your twitch.
Yeah, okay. Oh, he's
Hold it down. Okay. So it's working. So, but we didn't really give him that much. Okay, so let's say you see, if it's working, what are you going to see out there?
If the roxuronium's working, you want to no twitch.
Nothing.
Nothing.
Ideally, you're going to be down to almost nothing.
Mhm.
No twitches, no tetany. Okay.
Okay. Sweet. Let's see, Gladys. good view with this Mac 3.
I'll turn that off. Go ahead.
There we go. See the cords?
It'll take quite a bit of air in there, all of that, maybe just a little bit more. How do you know you got him intubated correctly?
I watched the tube pass through the cords. I've got fogging in my tube. I see chest rise with some breaths. I have end tidal plus, and I'm going to listen.
Can you hear okay?
Mm-hmm. 515, end tidal is 30, just a few, and then take my tube. Tube is secure.
Tube secure.
And patient's on the ventilator.
Anything you want to do after you put him on a ventilator? Or you're just going to hook it up, turn it on, what are you going to do after you do that? You were ventilating, you knew you were by hand.
Mhm.
You put him on a ventilator, how do you know now?
I'm assessing my billows, which is not
Okay.
flux. There we go. Billows, end tidal, where it needs to be. So I'm setting for 550, and we're at
Good. Anything else you want to do? All your numbers look good over there. Your machine looks good. Anything else you want to do? Are you going to lift your patient again?
oh yes.
You're going to see the chest come
Chest
up and down.
rise.
You may listen one more time.
Okay.
After you
Put them on the ventilator.
After you put them on the vent, you make sure that everything's still good.
Okay.
Even though the numbers look good over there, you got to know they sound good here.
Okay.
Okay, so you've done all that,
So
and you secured your tube, and he's asleep right now. Anything else? Where are you going to go right now before you start?
I'll put on my antibiotic.
Okay? You got your antibiotics going. How are you keeping him asleep?
I'll turn on some SIBO.
You want SIBO? Okay. How much do you want each one?
60-year-old male. Let's go 0.8. See what at
0.8%.
0.8% SIBO. See where I land with that.
0.8%. Okay. Surgeon comes in and he's ready to start. Can he start?
Well, we need to do a timeout.
Okay.
Everyone in the room takes their role. Patient allergies, what are you getting done?
Okay. And timeout was good. Everything's good. Can he start?
I'd like to get 50 fentanyl
Okay.
for incision. Second stimulating thing of the procedure.
You can go ahead and get that. What are the two most stimulating times of the procedure?
Intubation and surgical stimulation.
All right.
1 mil, 50
Turn here.
milligrams given.
Yeah, you got it. I'm sorry. I saw it wrong. You're right. So he had 50 more mics of fentanyl, and you've given muscle relaxant. Is it still sufficient for him to do gallbladder? And if it is, what are you going to see?
Well, I will see no twitches if we're sufficient.
Okay.
Because we don't want him perking.
Good.
We don't want the patient bucking.
Okay, so can you start?
Yes, he may start.
Okay. So he's,
Well, let's see. Hypertension. Is he deep enough? I'm gonna get him deeper.
so what do you want to do?
I'm gonna crank this to 8 and I'm gonna turn up my flow to like
You
10.
want your C-roll on 8%?
But with my hand still on it, I just wanna, get him a little deeper. But my hand never left the dial, so I don't forget.
Okay.
And then he's 1.2. I turned it down a little bit to say usually the way 4 to get me, stable, kind of equalize from 0.8 to where I want him about just over 1, just at a 1 for surgical stimulation. Turn my flow back down to.
And when you tell me 1, are you talking about percent, or are you talking about a
I'm
MAC?
sorry, I'm talking about a MAC.
A MAC.
Yes, sir.
Okay.
My apologies. A MAC of 1.
Okay. All right, so you did that. You've still got this up here going on. What do you want to do?
I checked his twitches. He has no twitches. I've turned up my gas. Gave him fentanyl.
Looks like your gases are starting to work.
Okay, we're at 2.
And now you want to be back down to, you said 1 MAC, right?
Yes, sir.
Okay. And when you told me originally SIVO at 0.8%.
That was a 0.8 of MAC.
A MAC.
Yes, sir.
Okay.
My apologies.
Okay. Make sure I'm getting what you want. Okay, so you treated the hypertension with more agent.
Mhm.
Let's say you didn't think it was that hypertension, you would try that, but what else could you have done if that had not responded? What would you have done besides the inhalation agent? What could you have done?
IV.
Okay, what would you use?
Well, on induction I gave 100 fentanyl, so I gave 50. So making an additional 100 fentanyl.
Okay, so you think it is the depth of anesthesia?
Yes.
What if it wasn't? What if you determined it was not the depth of anesthesia, that he was not light? What could you do? Is there any medications you ever use to bring down the blood pressure?
Yeah, let's go ahead and give some, he's tacky, so let's go ahead and get some Esmolol.
Okay.
It has a short half-life, so.
What would you give me?
5.
5 milligrams?
Yes.
Okay, I think that's good enough. I want to know that that's what you would be doing. Okay, looks like you got him pretty good, and the surgeon has started working. From what I'm seeing, it looks like you're in control of everything. Pulse is good, blood pressure is good, SpO2 is great. You got him on a ventilator. His capnograph looks good. End-tidal CO2 looks good. Everything is just sailed through here. Is there anything that you want to think about now that?
Yeah, we'll go ahead and, is Mr. John a diabetic?
No.
Okay, we'll go ahead and give him 4 Decadron.
Decadron?
And 4 Decadron. Now this Dr. Coy, he's pretty quick on his gallbladder.
Okay.
So.
Do you usually give anything other than Decadron? You're giving that for what reason?
Antiemetic.
Okay, do you give anything else?
We'll get 4 Zofran.
Zofran?
Yeah.
Okay, we're giving both of those. Okay, and he is through now. So, what do you want to do? How are you going to end this case?
Let's go ahead and just cut this back.
Back or off, or what do you want?
His PA is very quick with the suturing as well, so I'm just going to turn it off.
Okay, because they're done now.
Yeah, I'm going to turn that off. I'm going to check my twitches.
Okay. What do you see?
I got 3 twitches.
Okay, let's say you only see 2.
2?
What would you do?
Let's see, 0.05 times 70. I have to add that up.
What drugs are you going to get?
neostigmine and robenol.
How much does it mean?
I'm gonna go 4. It was 3.55. Yeah.
Glycopyrrolate.
0.6 milligrams.
Okay. And after you give that, you're gonna wait how long to see it?
At least 15 minutes.
Okay.
10, 15.
To get the maximum effect. But you're gonna see something before that, aren't you, in here?
I'm gonna see him try to breathe on his own.
Okay. So you give it. He's already got 2 twitches.
Yes.
He's gonna come back. And what have you told me you backed off the SIBO, and let's say you check that again, and you're seeing what you really see right now. You got 4 twitches with what?
With no pain.
Okay. Is he still on the vent?
Yes, his end-tidal SIBO is now 0.4, 0.3, 0.4.
Okay.
Titrating down, he's kind of just, from the time I turned it off and turned up my flow to help get it off. So I'm just going to turn this off.
Okay.
And then I'm going to see what he does.
All right.
With my hand on the bag. Okay, yeah, I feel that. He's taking some breaths.
Is he? Good.
And to help get that SIBO off, I like to kind of, go with him. Bigger tidal volume to help blow it off more.
And you're on, what are you on now? 100% O2, right?
100% O2.
Okay.
O2 is turned all the way
Yeah.
to 10 liters, 15.
You waking up for you yet?
Hey, Mr. John. Mr. John, can you open your eyes? Okay, he's still asleep. And another thing I'm doing, I'm just go ahead and suction him out.
Okay.
Prevent that laryngospasm.
Yeah.
And he has a good set of teeth, and he's a pretty thick guy. So I'm just going to put in an oral airway. I don't want him to clamp down on that tube.
All right.
So with my tongue suppressor.
Okay.
Okay. Getting that in. Okay, SIBO's at 0. Mr. John, open your eyes. Can you open your eyes?
See that all his breathing now?
And we're breathing at a rate of 18, 17. 19.
So you pretty much ruled out everything. You know his muscle relaxants been reversed. Your gases are off. He's flushed out. His SpO2 is good. His end-tidal CO2 is good. He's just not waking up. I think you handled this great. I think you put the word on our way in. So when he starts blinking, do you take him out before they respond ever in the tracheal tubes?
I'm sorry, what was that?
Do you ever extubate before they're open?
No, they don't. They do not extubate at training.
Okay.
They want.
Let's say he's opening his eyes now then.
All right, you open your eyes. Excellent. You go ahead and squeeze my hand. Good strong grip. This is the last thing to come back, so I would expect that.
Okay.
Strong grip.
Okay.
All right, take a big deep breath for me.
What's another really good way to determine whether
Lift his head off the pillow.
Okay. How long?
5 seconds.
Okay.
Can you lift your head up?
Hey, look there, he's even waking up for you.
All right, we'll get that tube out and suction him out one more time. Okay. All right, nice big deep breath. You're doing great, John. We're all done, sir. All right.
Okay, so you are through. You're in the recovery room. Tell me the report you're going to get.
The most important thing first. This is John, and he had gallbladder surgery. There is no critical information such as patient received blood or was on a neo drip or anything.
Okay.
No critical events during the procedure. But if there was, I would say that first.
Okay.
Allergies, say the procedure, what you got for antibiotic, blood loss, fluid volume, what you got for pain, antiemetic, urine output, like you said, blood loss, intake output. He did great in the case, maintaining his airway, on a face mask. Are you in any pain, John?
No, I'm good.
Good.
How did you
Excellent.
transport him to the recovery? You
I was
guys
just-
use O2 down there to transport?
Yeah, we have a tank and just a
Okay.
face mask on 10
Okay,
liters.
so that's how you transport him. He didn't need any other monitors, he was a
Mm-mm.
healthy guy.
Mhm.
Okay, good. And I always tell people too, if I reverse somebody, I just let them know that I reverse the
Fully
muscle
reversed,
relaxants. And that, where that becomes critical, I think, is that if you had to reverse the muscle relaxant, you actually had to. You weren't just doing it out of principle, but you reversed them. And is there a chance that whatever muscle relaxant you used, if you used a long-acting one, that he could get into problems still?
Mhm,
Yeah,
most
he could-
definitely.
So I always tell them, in my mind, tell them that you reverse the muscle relaxant. So they know, at some point it was reversed. If you're using something like rock, I've never seen anybody get blocked
Mhm.
where it outlasted. But if you're using something like pancuronium for some reason, you can have a problem 30 minutes an hour into the recovery nerve.
Okay.
Where your reversals kind of wear off, and you've still got that muscle relaxant there. Okay, good job. All right, and good handoff. And one thing I'm stressing with people is that handoff is really, really important.
Mhm.
Whether it's PACU or if somebody had come in here and relieved you, it's your responsibility to pass on everything pertinent.
Mhm.
If you're, in the next year, you're gonna start doing some bigger cases. Have you done any aneurysms or
I've
big
done,
valves or?
I've done one AAA.
Okay.
No, sorry, 2 AAAs, and Mandy left me off the schedule on a Friday, but then they had a meeting that I showed up to at 6 in the morning, so I figured I'd ask her then. She wasn't there, so I just kind of like, hey, can I do a AAA? And that patient didn't go because they had a rash in the groin area, obviously. So did another case, which was a aortic valve replacement, but I said, hey, I don't feel comfortable sitting at the head of the bed, but can I watch? And I watched that. That patient actually had a 7 millimeter aneurysm.
Okay.
So the decision was which one to do first, was they replace the valve first.
So just know that when you're starting to do some of those big things, fluids in, fluids out, really make a big, you need to keep track of it big time. I used to keep paper back here, if I give 3 or 4 units of blood, I mark them down, so if I have to get relieved, they don't have to go through my chart and just count up what I've done. I may have a worksheet of my own, how much urine's come out, what liter is up here. Is this number 2 or is this number 7 up there? So that you're making sure that information gets passed on, which can be critical. Basic things, but basic things can make a huge difference. Okay?
Yeah.
Good. I think you're done. You were done. You survived it. You bet. She'll be in there in just a little bit. That's what did it.
Am I supposed to start already?
Everything's been under control.
I need to drink water. I need to go to the bathroom.
Okay. You come in first thing in the morning. You don't really know what you're going to be doing other than you're in OR 10.
All right.
So they tell you just go back, set up the